Hello everyone, this is Dr. Noshin. Today we are here with another topic from behavior and psychiatric illness. The topic is Encopresis or swelling in children's. So this is defined as repeated repeated passage of stool in inappropriate places, like maybe in park, maybe in public. It it could be voluntary or involuntary, but this is mostly involuntary. Okay, the age should be 4 years or more than 4 years. Why this is the cutoff? Because before 4 years, if the swellings occur, this could be normal, because there is a limited cortical control over defecation. Before 4 years, the child cannot reliably recognize the urge, go to toilet on time, delay defecation. But after 4 years, when it's happened, this is called pathological. This is called encopresis. After 4 years, the brain gut coordinations improve. Voluntary control over the anal sphincter is improve. The voluntary control is over the external anal sphincter, because it's made of skeletal muscles, is improve. Okay, so that's why we call it after the 4 year, not before the 4 year. Okay, now what is the classification? There are four types of encopresis. The most common type is retentive encopresis. This is most common. From exam point of view, if students are listening to me, this is 90% cases have retentive encopresis. Let's talk about what is retentive encopresis. This is mostly because of constipation. Constipation maybe start with holding the stool. Maybe the child is not there. Maybe the child is in public, the toilet is not there. Maybe the child have some fear. The child holds a stool. We will discuss the mechanism. Like, the child holds the stool becomes harder because the water is reabsorbed. The stool becomes hard like a stone, and the impaction occur. Okay, and there is another stool made over, that's overflow. So this is retentive encopresis. This is the most common, right? There are other types like continuous and discontinuous. What is continuous? This is non-retentive. That means that the child never achieve bowel control. Okay, maybe they're because of poor training, maybe because of developmental delay. Okay, could be the both reasons. So this is the continuous. The discontinuous means that the child have a good bladder control. The child was fine for few months, maybe 6 months or 1 year, have a good control. They go to use the toilet, never accident in the public or any place, inappropriate places. Then suddenly the child have this problem, maybe because of some stresses, maybe their parent separations, maybe some trauma, maybe some fear. Okay, so this is discontinuous type. And one thing is toilet phobia. Some childs have fear to go to washroom, maybe because of the sound of the flush, maybe because of the cupboard itself. They avoid to go to the washroom. Okay, so this is called toilet phobia. So this is a rare type. The most common is retentive, and here is again the pathophysiology, the vicious cycle is mentioning over here. Like, maybe the child have painful defecation. Okay, maybe the child have painful defecation, right? Which leads to fear of defecation. The child avoids defecation. Okay, not want to go to washroom. Then this is the stool holding. Okay, with holding stools, the stool becomes hard like a stone. Why? Because when the stool is accumulated, the water is reabsorbed, as I told you before. So this is results in rectal distension, which is called megarectum. The rectum become desensitized. Normally what happens when the rectum is full, there is sensitization occur. The signals goes to the brain for rectal fullness. Okay, that's normally fully develop at the age of 4 year and after onwards. Okay, so when the megarectums occur, the rectum become desensitized. Don't the signals to the brain not go properly. Then what happened? This is called desensitization, reduced sensation, and this is a vicious cycle. The more stool form that is on the top, which is soft, may come out. That's called overflow. Let's talk about this now. This is when the child presents. You may say this is diarrhea, but actually this is the myth. Okay, this is not diarrhea. Why this is not diarrhea? Because when you do a proper history examination, you will see that there is a lot of stool. There is a history of constipation. There is a lot of stool. There is an impacted stool on the rectum, and there is history of constipation. Okay, so actually this is the overflow, because the stool is coming. The soft stool leak from the sphincter, from around the impacted stool. Okay, so this because the rectum is full but sensitization is gone. The child not aware that I want to go to the washroom, and the stool involuntary come out. Okay, now what you will do, I hope you understand yet. Okay, so what will you do at first when the case of soiling case comes in your clinic? The mother come with a patient, with a child that have some because this is like a trauma for the parents, right? Not even with the child, with the parents too. So when the child comes with their mother in the clinic, you have to take the history. You need to know that at what age, you need to know at what age at toilet training. You need to know the frequency and consistency of the stool, pain during defecation, there is a any stress element. You need to take all history. Okay, and in examination you can feel palpable fecal mass. You have to check the neurological examination, and let's do it over here. Okay, now you have to check the perianal region for fissures, for stool in the rectum, ampulla, or the tone. Okay, so this is the physical examination history you should take with parents for the child. Okay, now before we label the child as encopresis or swelling, okay, you should done with some differentials. Okay, what's the differential? This is called Hirschsprung disease. What is Hirschsprung disease? This is the congenital, neurological, and structure problems in the rectum. So you need to rule out the hypothyroidism, because in hypothyroidism there is a chronic constipation. You need to rule out any neurological disease, hypercalcemia, anal fissures, which all result with the same scenario. Okay, but you should know that the functional encopresis is the diagnosis of exclusion. You should first ruled out all this, that this is not, and then you will say this is encopresis. Okay, you just not say the patients come, the child's come, you label it as encopresis. No, you first have to differentiate. You have to remove all the differentials, right? Then you can label the child as encopresis. Okay, now what is the management? What is the management in a child? Okay, first thing, what actually happening in the clinics, may doctors do, may parents do, start with dietary habit changes. Okay, but that's come last. The first step is to clean out. Okay, this is the first step. The first step is disimpaction, means you need to clear the bowel first. Before doing any treatment, you have to remove the impacted stool which is present from a long time in the rectum. Okay, How will you clean out? You can use high dose of laxatives, stool softeners, maybe enema to clear the bowel. Okay, this is the first step. Before starting the maintenance therapy, you cannot go to the second step. You should do this step first. Okay, then the next step is maintenance and retraining. Okay, this is the next step, maintenance and retraining. How will you do the maintenance? After the disinfection, after the clearing the bowel, you have to continue for months some stool softener medicine, some mineral oils, because what actually happened when you know the pathology, like there is a mega rectum, there is a desensitization. So this desensitization, shift to sensitization will takes time. Okay, so you need to continue the child on maintenance. You should give for months, even for 4 to 6 months or 1 year, the maintenance softeners, stool softeners, some minerals oils, because the mega rectum come back to its normal position, the sensitization will develop with time, then the child knows about the rectum fullness. Okay, what parents will do when the stool becomes soft, maybe takes 1 day, 2 day, 3 days, or maybe it takes a week, the parents stopped the maintenance therapy because they thought that my child is fine now, no need for olive oil, no need for stool softener, as my child's stool is already soft. But the child's come back again because of the desensitization of the rectum. Okay, you need to understand this. So this is what maintenance plus retraining. What is retraining? That you start the train the child once again, like with every meal. Ask the child after the meal go to the washroom for at least 5 to 10 minutes. Why? Because of you take the advantage from the gastrocolic reflex. Okay, you take the advantage, the child will sit, do the poo, so it clear the bowel with every meal. Okay, for at least 2 to 3 times. Okay, so this will, the stool will not hold, there will no chance for constipation, the rectum is empty every time, the rectum will not fold, the rectum mega rectum come back to its normal position, sensitization develop again. So this is a process. Okay, the next step. Okay, so this is the process. The next step, I hope you understand, the next step is management. The fourth and the fifth step is the lifestyle, the dietary habit. What we are doing, we start with dietary habit first. If the child have constipation, we advise drink water, drink this, eat that. Okay, but we don't think about disinfection, we don't think about the maintenance and retraining. We start with this lifestyle modification and behavior modification, which is wrong. Okay, when we start from the first step, when we come towards a lifestyle behavior changes, we have to increase the fiber and fluid intake in child's diet. We reduce the excessive milk intake because it causes constipation. And you know what? You need positive reinforcement. Like if with every stool passing, you need to remove the toilet phobia or fear from the child. You should give award, like you need to make reward charts, reassure the child. It will make the child happy. The child will learn to defecate, to pass the stool is not the bad thing, is not the fear thing, it's not the painful event. The child will automatically learn the behavior. So don't punish your child, don't shame your child and say that how much old you are and you are doing this and that in public, what you are doing. Don't punish your child. Okay, so this is the management of encopresis or swallowing of the child. I hope you understand the video. Let's start with some MCQs for, let's check how much you learned from me. Okay, so this is the first case of 6-year-old child with chronic constipation. Okay, what the child have? The child have chronic constipation. Okay, that presents with swelling. Okay, the most likely mechanism is diarrhea, anal sphincter weakness, overflow incontinence, or Hirschsprung disease. So this is a case of overflow incontinence, right? This is not the diarrhea, not the anal sphincter weakness, not the Hirschsprung, because of the chronic constipation. This is the key point. You should know that the chronic constipation lead to infection, liquid stool leaks around the hard mass. It's not diarrhea or sphincter weakness. Okay. The next question is that the most common type of encopresis is, what is the type? The most common is non-retentive, toilet phobia, retentive encopresis, neurogenic. So the most common is the retentive encopresis, right? So 90% cases have this. Okay. Now the third question is that the first step in the management of retentive encopresis is behavior therapy, dietary fibers, psychotherapy, or removal of fecal impaction. The answer is D, removal of fecal impaction, right? This is the first step. Okay, you need to remove the blockage first before starting the maintenance. Okay, the fourth question is that swelling in encopresis is best described as voluntary defecation, diarrhea. The C is overflow of stool and infection. The answer is C. The answer is C, overflow of stool. Okay, this is the overflow because the liquid stool around the infected fecus comes out. Okay, so this is not the infected diarrhea or voluntary action. Okay, this is involuntary. Now the fifth question is, encopresis is diagnosed only if the child is at least 2 years, 3 years, 4 years, 6 years. The answer is 4 years. Okay, the answer is 4 years, right? This is the developmental age, at least 4 years. Okay, so take home message, keys you should know that encopresis is repeated swelling in children for at the age of 4 or plus. Constipation is the root cause, main cause, 90% retent, because the most common type is retentive. So the constipation is occurring retentive. So most common root cause is constipation. Swelling is due to overflow, not diarrhea. Management step is always disinfection, right? Treatment required patience, long-term follow-up. So this is all about encopresis. I hope you like the video. Please do subscribe to my channel. For next, we will meet inshallah in next video. Bye.